Neonatal respiratory distress syndrome, infant respiratory distress syndrome, surfactant deficiency disorder, hyaline membrane disease. These are all names of a single disease. Neonatal respiratory distress syndrome. Before proceeding, pathophysiology of neonatal respiratory distress syndrome. There is surfactant deficiency in lungs, which causes the alveoli to collapse. Collapsed alveoli have little or no air, which leads to respiratory distress. Neonatal respiratory distress syndrome or surfactant deficiency disorder is a lung disorder in infants that is caused by a deficiency of pulmonary surfactant. It is most common in preterm infants, with the incidence and severity decreasing with gestational age. Surfactant deficiency causes the alveoli to collapse, resulting in impaired blood gas exchange. Risk factors of neonatal respiratory distress syndrome: premature birth, maternal diabetes mellitus leads to increased fetal insulin, which inhibits surfactant synthesis; hereditary, mutations in genes producing and transporting surfactant proteins; cesarean delivery results in lower levels of fetal glucocorticoids than vaginal delivery, in which higher levels are released as a response to stress from uterine contractions. Glucocorticoids promote surfactant synthesis. Hydrops fetalis, a fetal condition characterized by generalized edema and accumulation of fluid in serous cavities, for example pleural, pericardial, and abdominal cavity; multifetal pregnancies; male sex. Epidemiology of neonatal respiratory distress syndrome. Incidence. Incidence of neonatal respiratory distress syndrome in all newborns is 1%. Incidence of neonatal respiratory distress syndrome in all preterm babies is 10%. The risk of developing neonatal respiratory distress syndrome depends on gestational age. Less than 28 weeks of gestation, risk greater than 50%. Greater than 37 weeks of gestation, risk less than 5%. Surfactant. Pulmonary surfactant is a mixture of phospholipids and proteins produced by type II alveolar cells. These phospholipids reduce alveolar surface tension, preventing the alveoli from collapsing. Surfactant deficiency is most likely to occur in preterm infants because surfactant production begins at approximately 20 weeks gestation. Distribution throughout the lungs begins at 28 to 32 weeks gestation and does not reach sufficient concentration until 35 weeks gestation. And due to surfactant deficiency, there will be little or no reduction of alveolar surface tension, thus increased alveolar collapse, known as atelectasis, which leads to hypoxemia and hypercapnia. Hypoxemia and hypercapnia will cause respiratory acidosis. Due to respiratory acidosis, there will be increased permeability due to alveolar epithelial damage, which leads to fibrinous exudation within the alveoli. Thus, hyaline membranes in the lungs will develop. That is why neonatal respiratory distress syndrome is also called hyaline membrane disease. Before proceeding to this slide, eosinophilic means pink and basophilic means blue. Hyaline membrane in neonatal respiratory distress syndrome. The alveolar walls are lined by eosinophilic hyaline membranes. The normal basophilic alveolar epithelial lining is absent. Within the interstitium there is an extensive inflammatory infiltrate which is visible as numerous basophilic nuclei. Large basophilic nuclei, macrophages, multi-lobe nuclei, neutrophils. There are numerous microthrombi visible as extracapillary aggregates of RBCs. The capillaries appear congested. Loss of alveolar epithelium, presence of alveolar hyaline membranes, and interstitial inflammation, edema, and congestion are the typical features of the acute exudative phase of acute respiratory distress syndrome. Clinical features of neonatal respiratory distress syndrome. History of premature birth. Onset of symptoms usually immediately after birth but can occur up to 72 hours postpartum. Signs of increased respiratory effort: tachypnea, Respiratory rate greater than 60 is indicative of tachypnea in neonates, nasal flaring, and moderate to severe subcostal, intercostal, and jugular retractions. Retractions are caused by the use of accessory respiratory muscles. Characteristic expiratory grunting. Affected infants exhale through a partially closed glottis, limiting alveolar collapse in an effort to increase intrapulmonary pressure. That is why a sound or voice is produced which is called grunting. Decreased breath sounds on auscultation. Cyanosis due to pulmonary hypoxic vasoconstriction. Cyanosis, which improves on oxygenation, is of pulmonary nature, while cyanosis, which does not improve on oxygenation, is more probably of a cardiac cause. Neonatal respiratory distress syndrome is diagnosed based on clinical features, history of preterm birth, X-ray chest, blood gas analysis. On X-ray chest, there will be interstitial pulmonary edema with perihilar streaking, diffuse fine reticulogranular densities with low lung volumes and air bronchograms, atelectasis, blood gas analysis, hypoxia with respiratory acidosis may lead to increased lactate levels, evaluate for partial respiratory failure or global respiratory failure. Amniocentesis for prenatal testing of neonatal respiratory distress syndrome. Amniocentesis is used to screen for markers of fetal lung immaturity. Lecithin's sphingomyelin ratio less than 1.5, greater than 2 is considered mature. The amount of sphingomyelin in the amniotic fluid remains relatively consistent during pregnancy. The amount of lecithin, which is the major component of surfactant, starts increasing after week 26 of gestation. The lower the lecithin sphingomyelin ratio, the more likely it is that the lungs are immature. Respiratory distress syndrome, X-ray chest, AP view. Here lung volumes are low due to atelectasis as compared to a normal X-ray. Here is an air bronchogram. These are reticulogranular ground glass densities or opacities, endotracheal tube, nasogastric tube, CVP line. The lungs show a diffuse granular pattern with low volumes. Diffuse because surfactant deficiency in whole of the lung. Also, an air bronchogram can be seen. Endotracheal and nasogastric tubes are present. There is also a left central line. This is the same X-ray with overlay. The lungs show a diffuse granular pattern with low volumes. Also, an air bronchogram, example indicated by a green overlay, can be seen. Endotracheal red and nasogastric tube yellow are present. There is also a left central line blue. Neonatal respiratory distress syndrome, X-ray chest frontal view of a premature infant. The lungs are opacified and have a granular appearance. Neonatal respiratory distress syndrome, chest X-ray, X-ray chest of a premature infant. As surfactant deficiency is in the whole lung, so there are diffuse reticulogranular or ground glass densities or opacities in both lobes of the lung. Before proceeding to this slide, here you can see pleural lining of right lung. This is indicative of tension pneumothorax. Respiratory distress syndrome, X-ray chest. A right tension pneumothorax has developed. It is accompanied by depression of part of the right hemidiaphragm and leftward shift of the mediastinum. The right lung is partially collapsed. A chest tube has placed in the lower hemithorax, and endotracheal tube and nasogastric tubes are also present. There is also a left central line. Respiratory distress syndrome and X-ray chest AP view. This is the same X-ray with overlay. A right tension pneumothorax has developed. It is accompanied by depression of part of the right hemidiaphragm indicated by red line and arrow and leftward shift of the mediastinum indicated by blue line and arrow. The right lung green overlay is partially collapsed. A chest tube has been placed in the lower hemithorax, and endotracheal and nasogastric tubes are present. There is a left central line. Treatment of neonatal respiratory distress syndrome. Ventilation. Nasal continuous positive airway pressure with a peak and expiratory pressure of 3 to 8 cm H2O. Continuous positive airway pressure is used for oxygenation of lungs. Peak and expiratory pressure of 3 to 8 cm H2O means that air with pressure of 3 to 8 cm H2O will always be present in alveoli to prevent atelectasis or lung collapse and to promote blood gas exchange. If respiratory insufficiency persists, start intubation with mechanical ventilation and oxygen inhalation. Endotracheal administration of artificial surfactant within 2 hours postpartum. Supportive measures, IV fluid replacement, stabilization of blood sugar levels and electrolytes. Physiologic oxygen saturation in neonates is around 90%. A saturation of 100% is considered toxic for neonates. Intratracheal surfactant administration. Intubation is necessary for intratracheal surfactant administration. Here, surfactant is being administered to lungs through endotracheal tube. Complications of neonatal respiratory distress syndrome, bronchopulmonary dysplasia, pneumothorax, patent ductus arteriosus. The persistently low partial pressure of oxygen in the blood contributes to patent ductus arteriosus, hypoxia, cardiovascular arrest, neonatal sepsis, complications of oxygen inhalation, retinopathy of prematurity, bronchopulmonary dysplasia, intraventricular hemorrhage, mnemonic for oxygen toxicity complications are RIBS, R retinopathy, I intraventricular hemorrhage, B bronchopulmonary dysplasia. Prognosis of neonatal respiratory distress syndrome. Mortality rate is less than 10%. Most cases of neonatal respiratory distress syndrome resolve within 3 to 5 days if treated promptly. Prevention of neonatal respiratory distress syndrome. Prevent premature birth if possible by tocolysis. Tocolytic medications are used to delay labor, thus buying time for antenatal corticosteroid therapy to promote surfactant synthesis. Antenatal corticosteroid therapy administered to the mother stimulates infant lung maturation, given 48 hours before delivery. 2 doses of intramuscular betamethasone 24 hours apart, or 4 doses of intramuscular dexamethasone 12 hours apart.